Hello and welcome to the Sarah Clinical Education Infectious Disease Podcast, formerly the CCO Infectious Disease Podcast. I'm your host, Kristen PharmD. Today's episode is the second of three taken from our live event on carbapenem resistance in critically ill patients. This episode covers strategies for overcoming diverse antibiotic resistance profiles in difficult to treat resistant Pseudomonas aeruginosa. I'm joined by Dr. Ryan K. Shields from the University of Pittsburgh. To follow along with the slides, please visit the show notes for this episode. Now let's get started.
It's a pleasure to be here, and I'm excited to talk to you about what we've learned in the last few years about how to manage some of these difficult to treat gram-negative infections. And we'll start with a pathogen that everybody in this room is familiar with, and that being Pseudomonas aeruginosa. So let me also start with a common scenario that many of you are seeing in your intensive care units. You've got an elderly patient coming in from a nursing home with a history of COPD and frequent exacerbations, coming to you again with cough and shortness of breath. And you've noted in their prior history that they've been treated for Pseudomonas aeruginosa in the past, and importantly, including meropenem, cephalopeninase trinam. The patient also has now ARDS, leukocytosis, and is hypoxic with 84% on room air. Subsequently, this patient gets intubated and sent into your ICU, and BAL samples are sent for culture, and again, you're using a lower respiratory tract multiplex PCR for testing. So Dr. Koloff has gone through how that's really helpful for Enterobacteriaceae, but what we know about Pseudomonas aeruginosa is that identifying carbapenemase genes is far less common in the United States. As you can see from the figure on the right-hand side of the screen here, less than 2% of carbapenem-resistant Pseudomonas in the United States harbor carbapenemase genes. This stands in contrast to what we see with the epidemiology at other places globally, but in the US, we don't really anticipate to see genes like NDM or KPC amongst Pseudomonas in many of our hospitals. We also don't expect to see ESBL genes like CTXM, for example. So we may be able to identify Pseudomonas early, but we really can't predict susceptibility testing based on the presence or absence of resistance genes, unlike what we can with Enterobacteriales. So often what we rely on in patients like this is their prior microbiology. And in this particular scenario, this patient is giving us a very important clue that they have been previously colonized or infected with a resistant Pseudomonas strain, as you can see on the slide here. Now, notably, this particular isolate is resistant to all the traditional anti-pseudomonal beta-lactams you've become accustomed to using. Meropenem, cefepime, piperacillin, tazobactam are all demonstrating high-level resistance in this case. So this may be spurring a number of questions that you're either asking yourself or discussing with trainees on rounds. What would you empirically want to start for a patient like this with a history of resistant organisms? Is there a role for combination therapy? And then where, if any at all, do the novel beta-lactams fit into this equation? And most notably here, you see two of them, ceftazidime avibactam and ceftolozane tazobactam, reported as susceptible. So we'll try to work through some of these considerations. Now, before I do, you've probably noticed something we like to do in infectious diseases is give everything an abbreviation, and we talk about MDR and DTR and KPC and CRE, and we have a tendency of throwing these acronyms around interchangeably. But for the purposes of this presentation, I want to very deliberately define MDR as being non-susceptible to at least one agent in 3 or more classes. But the category we're going to talk about today is difficult to treat, or DTR, which is a relatively new acronym that essentially represents to you that the isolate is resistant or non-susceptible to all the traditional agents, much like the case example we have today. So one of the things that's really shifted significantly in the last decade in our field of infectious diseases and antimicrobial resistance is we now very much target underlying mechanisms of resistance rather than reported susceptibilities or the pathogen themselves. Now, Pseudomonas aeruginosa is a bit more difficult to target one precise mechanism of resistance because oftentimes in Pseudomonas, we're dealing with organisms that are highly complex. They have very large genomes, including large accessory genomes that allows the organism to adapt in the presence of stressors like antibiotics. And there are a number of both intrinsic and acquired mechanisms of antibiotic resistance for Pseudomonas. The 3 that are most important to know for beta-lactams is number 1, beta-lactamases. Pseudomonas on their chromosome have an AMP-C cephalosporinase that can be de-repressed or overexpressed to make more enzyme. We also see that Pseudomonas has a number of efflux systems. One of the most common that's constitutively expressed or expressed at baseline is the MEX-AB-OPRM tripartite efflux system, which can also be overexpressed and cause higher level resistance to beta-lactams. And then finally, porin regulation. OPRD is the major porin in Pseudomonas, and when we see downregulation of those porins, it makes it increasingly hard for antibiotics to get into the periplasmic space where we know our beta-lactams have their mechanism of action. Now, as this relates to our traditional beta-lactam antibiotics, one of the things I want you to take away from this slide is notice that how each of these mechanisms has a differential impact on each of the agents we're talking about. There's some excellent examples here, and maybe some things that we've taken for granted over the years. For example, imipenem and meropenem, two carbapenems we often think of, well, carbapenem resistance is caused by the same mechanisms. But that's absolutely not true in Pseudomonas. In fact, imipenem is not a substrate for efflux whatsoever, where meropenem is, and meropenem is very incredibly stable against AMP-C and Pseudomonas, where imipenem can be hydrolyzed. So there are some inherent differences, and the key to know here is that resistance to one beta-lactam does not predict resistance to another beta-lactam in Pseudomonas. Unlike a Klebsiella that has NDM, where you'd anticipate all of your beta-lactams to be resistant, you have a very different scenario with Pseudomonas. So when we reference then the IDSA guidelines, this is one of the reasons why we differentiate DTR. We're really talking about the most resistant strains where you're not using your traditional beta-lactams. And outside of the urinary tract, what these guidelines will suggest to us is you have three preferred options, those being ceftolozane tazobactam, ceftazidime-avibactam, or imipenem-relebactam. Now, much like you, I often find recommendations like this to be a bit confusing. You're telling me three drugs should be preferred, but when would I know when I should pick one over another? And that's something I want to help you disentangle during the presentation today. So let's start with ceftolozane tazobactam, something that you guys have been familiar with using in your intensive care units. It's hard to believe that this is a new antibiotic that has now been available in our hospitals for over a decade. And over the course of that decade, we've learned a lot about ceftolozane tazobactam through real-world evidence. Not so much so that we have several meta-analyses now that have compared the efficacy of ceftolozane tazobactam to what we used to use prior to ceftolozane tazobactam being available, and that was largely aminoglycoside or polymyxin-based combinations. And what the genesis of those data suggests to us is that Pseudomonas aeruginosa DTR, when it's treated with ceftolozane tazobactam, as compared to aminoglycosides or polymyxins, you see higher clinical cure rates, greater microbiologic eradication, and certainly something we know about beta-lactams compared to polymyxins, much less nephrotoxicity or acute kidney injury. So the overwhelming data are compelling, and this is why ceftolozane tazobactam is one of the preferred options. You can see synonymous data with ceftazidime-avibactam. Again, when you're comparing to polymyxins, beta-lactams generally look good, particularly if they're testing susceptible in vitro. We see lower 30-day mortality rates in a small study, single-center study from China, and a larger multi-center study from Saudi Arabia showed, again, higher clinical cure rates, similar mortality, but lower incidence of acute kidney injury for patients treated with ceftazidime-avibactam. That's great, and so we know that both of those agents should be preferred instead of polymyxins, but what about comparing them to each other? One of the things we haven't done a good job with in infectious diseases is doing comparative effectiveness studies for preferred treatment options. And so this is a study that we did that was published earlier this year called the Cactus Study. This was a multi-center study across 28 centers in the United States, and we powered the study to enroll a total of 420 patients, with our underlying hypothesis being that ceftolozane tazobactam would actually result in higher efficacy compared to ceftazidime-avibactam. And the reason we made that hypothesis is that we know that ceftolozane gets into the lungs or has higher penetration into the epithelial lining fluid than ceftazidime and avibactam. Moreover, the MICs, or minimum inhibitory concentrations, tend to be lower for ceftolozane tazobactam than ceftazidime-avibactam. And those are two really important pieces of information in this calculation we like to do when we look at PK/PD target attainment, particularly in the lungs. So we hypothesized in this study ceftolozane tazobactam would be better, and we powered the study to test that hypothesis, which is something really important in real-world observational studies. Very rarely are they powered to be hypothesis testing. The second thing that we did that was really important about this study is if you're thinking back to your local facilities, you maybe have a stewardship program or a hospital formulary that guides you to preferentially use one of these two agents. And in fact, each one of our institutions probably has a little bit different approach to this same problem. Because of that, what we did is we matched patients one-to-one within each institution. So for every patient that received ceftolozane tazobactam, they were matched to a patient that received ceftazine-avibactam at the same hospital. We also matched patients by key determinants of outcomes, those being severity of illness, time to treatment initiation, and site of infection. We only included patients with pneumonia or bloodstream infections in this study, essentially excluding patients with urinary tract infections or intra-abdominal infections. Everybody received at least 48 hours of one of the two antibiotics, and our primary outcome was a composite of clinical success at 30 days, which we defined as survival, resolving signs and symptoms of the infection, and not having a recurrent infection within that 30 days. So as you move on to the baseline characteristics that you see on the right-hand side, one of the things that was most reassuring to us as investigators is the patients in this study were incredibly well matched. If you have the opportunity to read this study, you'll see in Table 1 that all of the underlying diseases, baseline demographics, severity of illness are almost identical between these two cohorts of patients, suggesting that our design to match patients within each institution worked really, really well. The other thing that was reassuring in this study is that these were the kinds of patients we were used to taking care of in our local hospitals. They were critically ill, 80% in the ICU, 70% were on the ventilator, 40% were receiving vasopressors. So this truly does represent then a real-world ICU population infected with multi-drug resistant Pseudomonas. So what did we find? Well, we found, in fact, that ceftolozane tazobactam did indeed manifest in higher rates of clinical success compared to ceftazine-avibactam. And what was really driving that clinical success at 30 days was not mortality, it was actually lower rates of recurrent infections. More specifically, what we saw as you move to the bottom left of the slide there, clinical success was significantly higher for patients with pneumonia and not necessarily those with bloodstream infections. And remember, this is analogous with our underlying hypothesis, that if ceftolozane tazobactam was going to be better, it would be better because it penetrated the lungs at a higher rate. And indeed, the pneumonia cohort is where we saw the greatest benefit of ceftolozane tazobactam. We saw no differences in mortality, but important differences in clinical success across a number of interesting subgroups that are listed on the slide. So the patient that we've talked about today was indeed successfully treated with ceftolozane tazobactam, and she was discharged from the ICU. But what happens so often with many of these kinds of patients is they end up coming back to us. And now they're even more treatment experienced. We've now used ceftolozane tazobactam for 2 weeks. The patient's readmitted to our ICU, and now the team's asking, what do we do next? Well, that's where I start thinking about some of the other antibiotics you've heard about today. Imipenem-relebactam, for example, is a newer antimicrobial that has in vitro activity against Pseudomonas, but has somewhat limited and concerning clinical data behind it. In the RESTORE-IMI-1 trial, this was compared to colistin-based regimens, and overall, it did better than colistin. Similar to what we've seen with ceftolozane tazobactam or ceftaz-avi, the newer beta-lactams are almost certainly superior to colistin or polymyxins. And indeed, we saw lower rates of acute kidney injury. But there seems to be a dearth of real-world available evidence for Pseudomonas specifically. In the HAP-VAP registration trial, where imipenem-relebactam was compared to piperacillin-tazobactam, there was numeric trends in favor of piperacillin-tazobactam and not in favor of imipenem-relebactam. So we have to learn more about this antibiotic in real-world studies, and another study we just published called the MIRAGE study started to capture some of this evidence. What was notable about studying imipenem-relebactam in the United States is, number one, it's very infrequently used in the United States, we found. But in the scenarios in which it's used, it was typically used after patients, much like our case today, had been previously treated with ceftolozane tazobactam, and this was a recurrent infection. Indeed, 54% of patients in our study had received other novel beta-lactams prior to receiving imipenem-relebactam, suggesting that the drug is likely being positioned for recurrent infections in most of those scenarios, which is personally how we position this drug at my university, the University of Pittsburgh Medical Center. And then what about cefiderocol? Well, many of you may remember the credible CR trial, which compared cefiderocol to best available therapy for carbapenem-resistant pathogens. Well, there was a Pseudomonas cohort within that trial, and there was no difference in all-cause mortality when you compared cefiderocol to best available therapy for carbapenem-resistant Pseudomonas. We also have some registry-level observational data from the PROVE registry, that is a growing repository of clinical evidence, suggesting that many of these isolates do indeed retain in vitro susceptibility to cefiderocol, and clinical cure rates are 65% and 30-day mortality just south of 20%. So another potential treatment option, but this in the IDSA guidelines is reserved as an alternative recommendation, largely because of these credible CR findings of higher mortality for patients that were co-infected with Acinetobacter specifically. Well, what about combination therapy? This is something that has been kind of come in and out of vogue over the years, and really one of the things that's changed most significantly about combination therapy is we used to use combination therapy for Pseudomonas out of desperation because we were using inferior antimicrobials like polymyxins or aminoglycosides. And oftentimes when you're using inferior drugs, you tend to combine them to reassure ourselves that we're doing something that's beneficial for the patients. But now we have a number of new novel beta-lactams, as we've just explained, that are very well tolerated. Well, what about the aminoglycosides specifically that's changing this pendulum a little bit? Well, the CLSI has recently evaluated all the clinical susceptibility breakpoints for aminoglycosides, and turns out at the doses we've been using for several years, they don't actually reach their pharmacokinetic and pharmacodynamic targets, particularly in the lungs. These are antibiotics we know don't penetrate the lungs well, and when you look at the MICs in relation to our exposures, many times we don't even cover the susceptibility breakpoints. Accordingly, amikacin and gentamicin have largely been removed as anti-pseudomonal agents for systemic infections, and thus tobramycin is the only agent that reasonably achieves those pharmacodynamic targets. But again, there's a lot of reservations around using tobramycin, particularly in combination therapy, which is why the IDSA says there's no evidence to support the use of combination therapy for Pseudomonas. So what are our take-home points for DTR Pseudomonas specifically? Hopefully I've shown you a little bit about resistance and how complex it is in Pseudomonas, and this idea that we really can't predict susceptibility from one beta-lactam to another because of these underlying mechanisms of resistance. In my clinical practice, because of our cactus study and other real-world evidence, we're prioritizing ceftolozane tazobactam for DTR Pseudomonas. We're using ceftazidime-avibactam if it's the only one that's reported susceptible for us, but generally speaking is our alternative agent. Imipenem-relebactam is then the next in line for us. If we are unable to use ceftolozane tazobactam or ceftazidime-avibactam, we'll test imipenem-relebactam. And cefiderocol we've positioned essentially for metallo-beta-lactamase producing Pseudomonas, which at this point are uncommon in the United States, but NDM are rising in Enterobacteriales, and it wouldn't be surprising to see them rising in other organisms like Pseudomonas in the future. So an important caveat that cefiderocol is the only one of these available options that has activity against MBLs specifically.
Thank you to our faculty, and many thanks to you, our listeners, for joining us. To listen to the other 2 episodes, please click the link in the show notes. To get access to all our new podcasts, subscribe to the DTR Clinical Education Infectious Disease podcast on your favorite player. Thank you and have a great day.